Good morning, everyone, and thank you for being here. Today, we are discussing the Ontario Ministry of Long-Term Care's proposed solutions for the challenges facing long-term care in Canada. My name is Deirdre Cleveland, and I'm from the Capacity and Health Workforce Planning team. I'm here with my colleagues, Andrea González from Policy Coordination and Intergovernmental Relations, Bill Liu from Long-Term Care Policy and Modernization, and Joon from Funding and Programs.
En bref, nous commencerons avec une déclaration de reconnaissance des territoires traditionnels, puis nous discuterons du problème et du contexte. Suite à cela, nous détaillerons la position de l'Ontario concernant la collaboration avec le gouvernement fédéral, les conditions proposées par l'Ontario, leur mise en œuvre, une analyse de risque et une solution pour améliorer les services de soins de longue durée. Nous conclurons notre présentation en détaillant notre stratégie de communication avec les parties prenantes. La région connue comme Toronto a été préservée par la nation Anishinaabe, la Confédération Haudenosaunee et les Hurons-Wendat. Elle est désormais le foyer d'un grand nombre de communautés autochtones, inuits et métis. Nous reconnaissons les titulaires actuels du traité, la Première Nation des Mississauga de Crédit. Ce territoire est soumis au traité de la ceinture Wampum, entente définissant le partage et la préservation pacifique de la région des Grands Lacs.
We will begin discussing background information, starting with the problem statement. A significant number of seniors are dying in Ontario's long-term care homes. To date, 73% of all COVID-related deaths in Canada have been in long-term care residents and staff. We have crisis level of staffing, funding shortages, and aging infrastructure. Our long-term care homes, as it stands, are reliant on low-wage part-time staff who are precariously employed. This issue is further aggravated by an inflexible long-term care funding model in which homes are not getting the funding they need. These conditions have been exacerbated by the lack of a federal approach to long-term care homes and chronic underfunding. As a result, current health outcomes for seniors are substandard, and long-term care homes are not prepared to handle COVID, even now. Therefore, we have to act swiftly and decisively to resolve this policy issue and to prevent further deaths. Canada's long-term care sector has been especially hard hit by the COVID-19 pandemic. More than 840 outbreaks have been reported in long-term care homes and retirement homes. While Canada's overall COVID-19 mortality rate has remained relatively low, LTC residents and staff have accounted for 73% of all reported COVID-19 deaths in Canada as of January 2021. This is due to systemic and chronic deficiencies in funding, infrastructure, and staffing.
Les établissements de soins de longue durée sont financés par le ministère des Soins de longue durée et par les frais d'hébergement payés par les résidents. En ce qui concerne le financement de la part du gouvernement de l'Ontario, ou plus spécifiquement les réseaux locaux d'intégration des services de santé, la majorité des fonds sont obtenus à travers un système de paiement pour différentes catégories de dépenses et qui est basé et ajusté en fonction de lits de soins ou bien l'indice de charge de cas. Et là, bien que ces mesures répondent effectivement aux besoins des résidents en termes de ressources, elle ne tient pas compte de la qualité de soins et des bonnes pratiques effectuées par chaque foyer, établissant de ce fait des mesures financières dissuasives pour l'amélioration de la qualité des soins et des résultats positifs. Cela s'ajoute au manque de fonds pour ces services au niveau provincial et une absence de fonds au niveau fédéral.
Staffing challenges in long-term care across Canada are well documented, including in the Canadian Armed Forces report on Ontario and Quebec homes that noted understaffing as a key issue driving COVID-19. The demand for long-term care positions has been outpacing supply for several years and will continue to do so if chronic staffing issues are not addressed. High employee turnover due to challenging working conditions and a lack of full-time employment availability, combined with rising resident acuity, has led to poor patient care as well as physical and emotional burnout amongst staff.
We are short more than 34,000 long-term care beds in Ontario, which means that many long-term care homes are forced to operate at full capacity with no space for COVID-positive residents to self-isolate as they share rooms and common areas with other residents. In addition, Ontario's long-term care homes are rapidly aging and need to be modernized. This was already a problem before the pandemic, but the COVID crisis has exacerbated the issue. Many homes need critical upgrades, including improving sanitation and ventilation standards. So here is a brief timeline of Ontario's response to the COVID-19 pandemic. Last March, Ontario declared a state of emergency and initiated social distancing measures. Throughout all of 2020, Ontario carried out numerous interventions to the pandemic, including releasing an outbreak guidance plan and protocols for long-term care homes, a COVID preparedness plan and invested $761 million to build 74 additional long-term care homes in Ontario. The Canadian Armed Forces and the Canadian Red Cross were also both deployed to assist homes last year. In November of last year and in January of this year, Ontario launched new initiatives on testing, as well as released incentives for both PSWs and nurses to return to work. The Ontario government, along with the Ministry of Long-Term Care and the Ministry of Health, are all committed to addressing these issues. In addition, Ontario has also publicly stated its willingness to work with the federal government on this area.
Our recommended solutions for long-term care across Canada take a multifaceted approach involving the following 4 pillars. Recalibrate funding by establishing a flexible model to sustainably address current and future needs. Reinforce homes by proactively designing spaces that are resilient to outbreaks. Regulate staffing and skill mix standards to ensure quality resident care. And reconnect long-term care with our communities by pivoting to a patient-centered care model that invests in home and community care for the future. The conditions that should be in place in Ontario before we can focus on our attention on a national strategy include the vaccination of 80% of staff and residents in long-term care homes, which will achieve herd immunity and is on track for completion by summer 2021. To address immediate staffing concerns, we will also be consulting with the Ministry of Labour to make the pandemic pay raises for long-term care staff permanent, which the Government of Ontario has publicly signaled its intent to do. We will also begin expanding the community paramedicine pilot programs to rural and northern Indigenous communities to address urgent needs there. Finally, we will implement a working group on accountability and transparency in long-term care homes to begin its mandate within 90 days. Conditions that we encourage the federal government to meet include the establishment of an FPT working group to develop recommendations for a pan-Canadian funding model. As the largest province, Ontario will offer to co-chair and help drive this issue forward. We are also requesting an exploration into amending the Canada Health Act and the Federal Provincial Fiscal Arrangements Act to extend coverage and funding to long-term care. To address staffing needs, we would like the eligibility for immigration caregiver pilot programs to be expanded to include long-term care homes, which could be piloted in Ontario whenever it is deemed safe by the Public Health Agency of Canada. To proactively address the future needs of long-term care, we would also like the federal government to consider developing national standards of design for long-term care homes, a national prevention and response plan for communicable disease outbreaks, and a commission of inquiry on disability and aging in Canada. To assist in these efforts, Ontario will offer our lessons learned from the first waves of the COVID-19 pandemic and the expertise of our ministries of health and long-term care in these areas.
We have also analyzed the potential risks that we could encounter with our federal conditions. In terms of the FPT group for a pan-Canadian funding model as a space to collaborate and provide recommendations for funding, we understand that there could be jurisdictional cooperation. For the amending of the Canada Health Act and the Federal Provincial Fiscal Arrangements Act, legislative processes may differ in time. Taking into consideration Quebec's civil law system, there may be a difference in legal integration and application between the provinces, and there may be disproportionate federal funding depending on the jurisdiction. The immigration caregiver pilot programs for long-term care homes may experience some level of resistance in provinces without staffing concerns. In terms of setting national or federal standards of design and IPAC for long-term care homes, we understand that there may be some limitations to regulations for private long-term care homes and some resistance from provinces who may not appreciate a federal oversight on these matters. Finally, we have not identified any potential risks on the exploration of a commission of inquiry on disability and aging in Canada. In terms of our COVID-19 immediate response solutions, we have identified 4 key themes and their respective solutions. To address the lack of funding, we are requesting the federal government for emergency federal funding adjustments to allow for COVID-19 safety within LTC homes. Moreover, restrict punitive funding measures for LTC homes during the pandemic. To address a shortage of staffing, we seek to explore incentives for students and unemployed people as care aides to meet staffing demands. For our infrastructure response, we plan to implement a cohorting system for all long-term care home residents, in which we separate residents based on their COVID status in order to reduce transmissions. Residents will be housed in red, orange, and green zones, whereas red will refer to COVID positive patients, orange will refer to residents suspected of being exposed to the virus, and green zones will refer to COVID negative residents. We will also improve rapid testing capacity for both residents and staff, in addition to fixing the PPE shortage. Finally, to address the future of disability and aging, we are proposing to use the iPads provided to long-term care homes at the beginning of the pandemic for their text-to-speech softwares, as well as the use of picture boards in different languages and existing medical dictionaries in Ojibwe, Ojibwe, and Cree to ensure culturally appropriate, inclusive, and accessible care for ESL residents with dementia that have regressed into the first language, which particularly impacts members of underrepresented groups, such as Indigenous persons, immigrants, or Francophone residents.
Nous détaillerons maintenant les éléments spécifiques de notre solution pour améliorer les soins de longue durée. En termes de solutions de financement, nous utiliserons les analyses et les recommandations proposées par le groupe FPT afin de développer un modèle de financement plus précis, flexible et effectif. Spécifiquement, nous commencerons en explorant une révision des modèles de financement juridictionnels existants qui fonctionnent à la base d'indices de charge de cas afin qu'ils considèrent le contexte dans lequel le soin se déroule. Pour préciser, on vise un modèle de financement qui prendra en compte la qualité des soins et des bonnes pratiques et qui récompense les résultats de santé positifs au lieu d'exclusivement les besoins. Ainsi, elle contribuera à améliorer les services et à augmenter le salaire des membres du personnel dans les foyers de soins de longue durée pour leurs efforts et contributions envers les soins des résidents. De plus, nous tenterons de continuer de fournir des crédits aux foyers de soins de longue durée en cas d'épidémie, tout en instaurant un niveau de flexibilité dans le financement et l'allocation des ressources. Nous viserons à instaurer des mesures ou bien des directives plus flexibles afin que les foyers puissent allouer les fonds dans les domaines qui en ont besoin. Ainsi, en cas d'urgence comme la pandémie, ils pourront diriger plus de ressources vers l'acquisition d'équipements de protection individuelle ou bien de kits de dépistage. Finalement, nous nous efforcerons de développer des nouvelles mesures d'inspection et d'audit en ce qui concerne la mise en œuvre et l'adhérence au modèle de financement révisé. Ces mesures viseront la collaboration avec les résidents en plus du personnel, promouvant ainsi la flexibilité et la qualité des soins.
On the theme of Regulate, our staffing solutions focus on ensuring good health outcomes by implementing a minimum standard of 4 hours of direct care per resident per day in long-term care homes. This will be scaled up gradually from the current average of 2.5 hours. In long-term care homes, 90% of direct care is currently provided by unregulated healthcare aides, such as personal support workers, but better health outcomes are demonstrated when direct care is shared between aides and nurses. Implementing minimum staffing and skill mix requirements in long-term care homes will ensure that residents are receiving the right quality of care in addition to the right amount. Unregulated healthcare aides often work part-time at multiple homes and have the highest levels of turnover in the healthcare sector. Emergency single-site rules for long-term care staff have helped to slow the spread of COVID-19, but also push an already precarious workforce into further insecurity. Shortages of nurses also demonstrate inequities in working conditions between the long-term care sector and other healthcare areas. Provinces and territories with funding from the federal government are encouraged to implement appropriate pay and benefits and make full-time employment available to all long-term care staff. This measure will address staffing concerns sustainably by reducing staff turnover and positioning LTC work as a dignified, secure, and satisfying career path for young Canadians. Additionally, this will increase resilience to communicable disease outbreaks like COVID-19 by reducing employee movement between long-term care homes.
So next we have our infrastructure solution under the banner of Reinforce. We encourage the federal government to invest in more beds, upgrade the built environment in order to proactively plan for the future. From 2011 to 2018, the number of long-term care beds in Ontario increased by only 0.8%, while the number of people over 75 grew by 20%. The waiting list for a long-term care bed now is over 34,000 people. The average waiting time is 161 days. We encourage the federal government to invest in building more beds. As an alternative are ALC beds in hospitals, which cost even more to build and maintain. This solution will work in conjunction with our paramedicine pilot program for northern communities, where paramedics will provide home care for those in need so that they're able to stay at home longer. Indeed, from 2018 to 2019, 1 in 9 Canadians that are in a long-term care home right now could have stayed at home longer, which represents 5,000 beds. Therefore, the solution improves the total care capacity of Ontario's long-term care services at a reduced cost. We will also proactively plan for the future, including creating a long-term care home pandemic response protocol to better respond to future emergencies. Lastly, we will upgrade the existing built environment. This includes retrofitting existing homes to meet minimum sanitation and ventilation standards. All the solutions for infrastructure are long-term, and we will seek to realize them over the coming years.
Under the theme of Reconnect, we have our future of disability and aging solutions. We are proposing a patient-centered and inclusive model of care in which cross-cultural education and sensitivity and bias training is available and mandatory to long-term care home staff. With the inclusive model, residents that are immigrants, racialized, francophone, or indigenous people, as well as any adult residents with disabilities or special needs over the age of 18, are able to receive culturally appropriate and adequate services. In addition to the minimum 4 hours of care per resident in our regulated solutions, we are also proposing a focus on patients' health needs and continuity of care by assigning each patient a personal support worker and a primary nurse provider. Continuity of care will also ensure that there is a focus on physical, mental, and cultural health and sensitivities. Our next solution works in conjunction with the implementation of the Ontario Health Agency, which is currently underway in our jurisdiction. We are proposing the integration of long-term care homes with community care services and home care services into the Ontario Health Agency to ensure that funding is further flexibilized and accessible. For other provinces, we are likewise proposing that the administration of long-term care homes and home care services is integrated. This would also make home care more accessible in remote areas, notably in Indigenous reserves. Many older Canadians are prematurely institutionalized in long-term care homes due to challenges in accessing home and community care support. To address this, we are proposing the Long-Term Care Insurance Plan, a public fund paid through income tax, which would increase funding for home care and long-term care homes. In this regard, as home care services become more affordable and accessible, waiting lists for long-term care homes aren't overwhelmed. To reiterate our policy objectives from earlier and to demonstrate how our policies are integrated within one another, we have illustrated them into this diagram. By recalibrating funding, we're able to develop flexible funding models that will sustain better health outcome. With more flexible funding, we are able to reinforce, reconnect, and regulate. By regulating staff, we are able to reduce inefficiencies and improve health outcomes through staffing and skill requirement, and avoid staff burnout through the implementation of appropriate pay and full-time employment. We reinforce infrastructure by building more beds, developing environmental improvements, and retrofitting long-term care homes to meet national standards of design and sanitation. Finally, by reconnecting with seniors and establishing a future of disability plan, we are able to develop accessible and culturally inclusive solutions for long-term care homes with a patient-centered approach that, going full circle, improves health outcomes.
In regard to implementing our solution, the mentioned elements will be divided and carried out in 4 specific periods consisting of immediate responses within 6 months, subsequent measures within 12 months, actions taken when transitioning from the pandemic between 2022 and 2023, and finally, measures that will be implemented from 2023 and onwards, specifically beyond the immediate dangers of the pandemic. In regard to emergency measures within 6 months, we will first explore implementing emergency federal funding while working to implement cohorting measures to long-term care homes. We will also explore pathways in employing students and unemployed persons for urgent staffing needs and improve rapid testing and PPE stocks in homes. We would also begin to include text-to-speech software and picture boards in care services. Within 12 months, we will work to establish the funding model and inspection FPT working group and begin a scaled implementation of care work standards, as well as start investing in new long-term care beds. In transitioning from the pandemic, we will work to implement cross-cultural and sensitivity training while investing in an inclusive and resilient long-term care home design. We'll begin the construction of beds in conjunction with infrastructural upgrades and begin the exploration of implementation of appropriate pay and full-time employment standards for long-term care staff. Finally, beyond the pandemic in 2023, we'll work to integrate a long-term care home, community care services while also continuing the construction of beds and infrastructural upgrades.
Pour terminer, nous parlerons de notre stratégie de communication. Les taux élevés d'infection COVID et de mortalité dans les foyers de soins de longue durée ont ébranlé la confiance des Canadiens. Nous devons rassurer les parties concernées par des messages clés sur l'amélioration de la stabilité du personnel et des conditions de travail, l'établissement de normes nationales de soins et l'amélioration des bâtiments, l'augmentation de la capacité de soins à domicile et de l'aide financière, et l'établissement d'inspections annuelles de qualité et de plans d'intervention en cas d'épidémie afin de planifier l'avenir de manière proactive. This concludes our presentation. Thank you so much for listening, and we're happy to answer any questions.
So team, thank you very much. I'm going to turn to my colleagues on the panel to see if they've got comments or questions. Let me start Janine Richaud, and then Steve Orsini, and then others. Janine, go first.
Merci beaucoup à l'équipe et je vous remercie pour la présentation bilingue. Félicitations pour ceci. Ma question est concernant la gestion de risque. Vous avez identifié dans votre plan qu'il y a certains risques, particulièrement vis-à-vis le fédéral et ce que vous planifiez, vos conseils à nous de porter à Ottawa. Mais je ne vois pas vraiment une stratégie de mitige de ces risques. Alors, quels seront vos conseils pour nous? Comment est-ce que l'Ontario pourrait utiliser son influence pour adresser les risques que vous avez identifiés, par exemple?
Who's going to answer that?
Merci. En termes de risque pour toutes les conditions, nous avons pensé à un plan de mitigation en termes de tous ces risques. Pour commencer, la difficulté en termes de coopération de la part de toutes les provinces et territoires. Nous pensons que le groupe FPT pourra aider à développer un espace dans lequel les provinces et les territoires peuvent tous apporter leurs problèmes et les solutions dans toutes leurs juridictions, en plus des concerns qu'ils ont, afin de développer un standard qui peut adresser les problèmes spécifiques. En termes de risques, en termes de problèmes législatifs, on a pensé qu'on pourrait émuler le Bill C13 qui a été développé en 2020, spécifiquement en répondant à la pandémie, qui pourrait aider à modifier les lois existantes en Canada. De plus, en termes de régulation concernant l'infrastructure et le développement de nouveaux infrastructures des foyers de soins de longue durée, on a pensé en termes de budget, comment on pourrait adresser ces issues. Et nous avons pensé que dans le transfert que le gouvernement fédéral nous donnera pour toutes les provinces et territoires, on pourrait adresser cela.
OK. Monsieur Chai, merci pour la réponse. Je vais passer la parole à Monsieur Fortier pour une question parce que notre temps est limité. Monsieur Fortier, André Fortier.
Merci, Jim. Merci pour la présentation. Just a question, just to make sure exactly what you're proposing. What would the impact would be when we go to the table of negotiations? If one of the criteria or the condition is to move toward more fully public-owned or non-profit long-term care facilities, what should Ontario's positions be given the importance of for-profit or non-profit private-owned facilities?
Who wants to take that question? Team, Andrea, Madame González.
Thank you. At the moment, our response is partially focused on, it is largely focused on providing more regulations to long-term care homes, whether they are public or private. In a 2014 study by the University Institute of Geriatrics at the University of Sherbrooke, it was demonstrated that after the 2005 regulations for long-term care homes in Quebec, 81% of private long-term care homes significantly improved the quality of care post-regulation. And as Professor Pat Armstrong at York University has argued, private long-term care homes had a much higher COVID-19 death rate of 5.2%, whereas in public long-term care homes, we had a much lower COVID-19 death rate at 1.4%. Therefore, while we are not currently exploring a position of moving away from the public and private model that we have, we do have significant evidence that regulating long-term care homes, whether public or private, results in better health outcomes, which is why we are seeking and calling for more federal oversight for all long-term care homes across Canada to ensure that our seniors and people with special care needs receive the best care and dignified care that they could receive.
Okay, thank you very much. Move over to Susie McDonald for another question.
Thank you very much for the presentation. Thank you as well for addressing the issue of marginalized communities. My question is about your implementation timeline in particular. I note that the idea of built environment upgrades only happens in 2022, 2023. Is there any plan to use the immediate transfer that we're hoping to get to do some of those upgrades? Isn't the issue of ventilation and PPE, you know, smart touch elevators, et cetera, important to controlling the pandemic right now?
Who's going to take the question?
I can take that question. Sorry. In regards to changing the built environment, we positioned that specifically when transitioning from the pandemic because the emergency federal funding will specifically be used for immediate equipment needs within long-term care homes. So as mentioned, PPE as well as testing kits. And we'll be also using that emergency funding to specifically help create these the zones that we mentioned earlier in terms of separating the residents to mitigate the risk of infection spreads within the long-term care homes. But specifically, the funding will be used for immediate COVID responses right now that we can reap tangible benefits from.
Okay, I've got time for a question from Ronelle Wilson. Madam Wilson.
Thank you. Thanks for your presentation. So I really appreciated the perspective around a lot of the solution around staffing. And I'm just curious around what thought we've given to where some of our PT counterparts might land with respect to some of the regulation around some of that staffing. And is that going to sort of impact where we bring that discussion at the federal level? And if we know or we've thought about some of our counterparts who are more likely to maybe land with us on that, have you given any thought to that?
Yes, definitely. So obviously all of our solutions come from an Ontario perspective, but we have taken into consideration the needs of other provinces and territories as well. And across Canada, staffing shortages are an issue in long-term care homes. And we believe that these solutions are best practices that will create better health outcomes for all residents within long-term care homes across Canada. So there are a few provinces who haven't noted staffing shortages as great of an issue. For example, Saskatchewan hasn't really seen, hasn't noted staffing issues to be as big of a concern as elsewhere in the country. But we do believe that most provinces and territories will definitely land firmly with us on this point because staffing is a huge concern across the country.
Okay, thank you, Madam. Steve Orsini, you had your hand up a while ago. Do you want, can I pass it to you or shall I take it? Go ahead.
No, go ahead, Jim.
So, colleagues, thank you for this excellent presentation. I'm interested in if you could tell us more about, you know, what you want from the federal government in terms of dollars in order to have Ontario buy into a national standard regime. I was very impressed with what you would do in Ontario, but I'm wondering if you could tell us more about how much federal money you want and how you propose to get it and whether you think the feds will give it to you.
So I can answer that question, and we can actually direct that that answer to Appendix B. Specifically, we're looking at the amount of the spending dollars provided by the the Health Integration Network in Ontario, specifically regarding how much they spend on long-term care funding. And we also revised the federal transfers in terms of health to Ontario. And we're hoping to emulate that the proportion of funds spent on long-term care as well, and use that in within the health transfer, specifically looking at a proportional increase that would be directed specifically to long-term care. You can see the number in red there is what we could potentially receive from the federal government in modestly. So we're looking at around $2 billion that could help at least mitigate the immediate effects of COVID-19 in terms of getting safety measures in place, and also help to implement the design and the staffing concerns that we had earlier.
So can I just quickly, is that new money you're looking at, or is that just a very slight increase on the money that we're currently getting in Ontario?
Theoretically, it is new, but it is a slight increase to what we're getting from the federal government. Yes.
Okay, so this is the feds will like this. You're telling us that you think the feds will like what you're proposing here in this package that you've put before us.
Yes, I think it follows the integrity of our funding models in Ontario and how the feds do provide money to Ontario for health.
Okay, I'll turn to my colleague, Steve Orsini. Steve, last question to you.
Yes, thank you. I appreciate the presentation and the follow-up questions and responses. And this really builds on Jim's question. The Premier's been calling for, all the Premier's been calling for 28 billion in total healthcare funding. So even if they want to hone in on long-term care, is the size of the provincial ask you're proposing, do you believe that's consistent to the amount the province are looking not only for long-term care, but maybe in healthcare in general?
Yes, I believe that the size of the amount that we're asking specifically for long-term care is proportionate to, first of all, how much the federal government funds provides money to the provinces in terms of healthcare, and also in line with how much Ontario does spend on long-term care. Ideally, we would obviously want a lot of money. The amount of money desired could be endless, but in terms of keeping the integrity of the system that we have in place and also immediately addressing the dangers that we are facing, we believe that this number, or at least this estimation, is an appropriate way to go about it.